Today I'm going to speak about the usefulness of extracorporeal shock wave therapy in muscular pathologies. I started from a definition. What is a shock wave? A shock wave is a propagating disturbance that travels faster than the speed of light. It can be produced, for example, from an explosion or a supersonic aircraft, or a lightning that produces a high pressure peak, a violent pressure peak. This graph shows the typical shape of a shock wave. It has an extremely fast rise of the curve with a very high pressure peak, more than 500 bars, followed by a negative wave that is weaker and longer respect to the positive one. It has an extremely short duration of about microsecond, less than 10 microseconds. This shape is characteristic of focused shock waves. Shock waves differ extremely from ultrasound, diagnostic and therapeutic ultrasound, due to the physics and the propagation and the biological effects. In fact, the ultrasound have a periodicity with low pressure levels and a characteristic propagation that is different from that of the high pressure peak shock waves. We know two main types of shock waves. On one side, we have radial shock waves, and on the other side, the focused shock waves. These two types differ from physics and from generation and from biological effects. In the radial shock wave, we have pneumatically generated by a projectile inside the handpiece that is accelerated from compressed air, and the peak of energy is higher at the tip of the handpiece, as we've seen in this figure, and then it rapidly low in intensity, so the higher action is in the superficial tissues, such as skin, subcutaneous fat, and muscle. The area of distribution of this radial shock wave is a point radial, is broader than the focused shock waves, and it can be propagated up to 3 or 4 centimeters of depth. On the other side, we have focused shock waves, in which we have a very high pressure peak that can be focused on the target area up to 12 centimeters of depth. The generation of focused shock waves, focused shock waves can be generated by 3 types of generators. The oldest one is the electrohydraulic generators. Then we have the piezoelectric, where the active crystals are electrically activated by electricity. And then the electromagnetic generators, in which we have a coil that is activated by electricity and induce vibration of a metallic membrane and a propagation of the shock wave into the water that are focused in a target area, in a predefined target area, by acoustic lens. What happens inside the tissues? The speed and propagation of the wave inside the tissues depends on the density, on the tissue density, of the medium density. During the propagation, the wave meets different acoustic impedance, different interfaces. And what happens at the different interfaces? We have 3 phenomena. A reflection in if the acoustic impedance is high, or a scattering or a transmission if the acoustic impedance is low. We can see that the air has a higher acoustic impedance, and that is why we have to use a coupling gel on the tip of the handpiece in order to allow a better conduction of the shock wave inside the tissue. This physical phenomena correspond to a biological effect inside the tissues called mechanotransduction. The vibration induced by the shock wave are transmitted inside the biological tissues and interact with transmembrane proteins that modify the cytoskeleton, the cellular cytoskeleton, and induce a higher gene expression and cell differentiation. This on the right is a study by Wong and colleagues of 2004 that shows how after stimulation with shock waves on human osteoblasts, we have a higher production of vascular endothelial growth factors, especially at 6 hours after the stimulation, with a peak at 12 hours. This interaction with the tissues cause a complex mechanism that leads to an increase of many growth factors, especially vascular growth factors that induce neovascularization and improved blood supply to the tissues with a consequent tissue regeneration. On the other side, we have also an anti-inflammatory and anti-nociceptive action mediated by the reduction in P substance in non-myelinated small nerve fibers and reduction in the production of pro-inflammatory cytokines. These mechanisms depend on the energy called energy flux density of the shock wave, that is a characteristic of focused shock waves. These EFD are collected in the focal area, in the target area of our treatment. We traditionally know 3 classes of EFD. The lowest one that acts mainly on superficial tissues, the medium one that acts on more deeper tissues such as tendons, ligaments and muscles, and the higher energy that acts on bone. The International Society and Italian Society of Shock Waves defined 4 groups of indications, especially the muscle pathologies are part of the second class, so common empirically tested clinical uses, and includes the muscle sprain without discontinuity and myofascial syndrome. The spasticity is part of neurological pathologies and is included in the 3rd group, only for expert indications. However, despite these indications, the literature research shows very few studies relative to treatment of muscle with shock waves. This is one of the preclinical studies analyzing the effect of low-intensity shock waves on human myoblasts after a biopsy from vastus lateralis muscles of young men, and in vivo studies on mouse skeletal muscle. They use low to medium energy and found that we have, after stimulation of both in vitro and in vivo muscles, we have an increase in vascular endothelial growth factor with 2 peaks. Some factors are increased at the 2nd day after treatment, respect to control that are not treated with low-intensity shock waves, while other vascular growth factor are increased at 21 days after the stimulation, with high capillary density in the treated group compared to the non-treated group. This other study is about an animal model of acute skeletal muscle injury on mice. They treat one group 1 day post-injury with this protocol, so a medium energy, and compare the results between the treated group and not treated group and the control that are healthy mice. We see that at 4-day post-injury and 7-day post-injury. We see that at 4-day post-injury, the muscular fibers are very disorganized due to initial proliferation of fibers that are, this proliferation is higher in the treated group compared with non-treated group, and we see in the healthy mice there are a very low proliferative activity because there is no damage. While in the 7th-day post-injury, we have larger diameter fibers, muscular fibers, and they are more tightened respect to the non-treated fibers and to the control. In this picture, we see the mitotically active cells, the nuclei, and we see in the treated group, both at 4 and 7 days post-injury, that we have a higher rate of mitotically active cells compared to the non-treated group and to the control that are represented by healthy mice, because the proliferation activity in the healthy muscle is very low. Moreover, we see that the treated group has the diameter of the fibers, muscular fibers of the treated group is higher than the non-treated one. However, it is less, lower than uninjured controls healthy muscle. There are only 2 clinical studies on patients relative to the treatment of muscle injuries with the shock waves. This is one of the 2 studies analyzing the effect of a low intensity treatment on patients with non-structural muscular lesion, delayed onset muscle soreness, compared with a non-treated control group. The authors here want to analyze the effect on anti-inflammatory effect and the effect on pain. As we see, the results are not statistically significant, so they can talk about a statistical superiority of shockwave compared with control, but the trend is positive. In the sense that the trend suggests a clinically considerable effect of focused shock waves in treatment these pathologies. This other clinical study analyzed the effect of focused shock waves on structural injuries, grade 2 or grade 3, minor or medium injury, diagnosed by ultrasound examination. As we see in the picture, we have a structural lesion of the hamstring muscles. They treated the patients with low intensity shock waves treatment 1 or 2 times at 3 weeks interval, and this treatment was associated with a therapeutic exercise protocol. This is the parameters that they evaluated, and they found a reduction in pain and an improvement in muscle strength, a reduction also in the diameters of ultrasound evaluation from a mean of 4 millimeters to 2 millimeters, and a mean return to sport of 8 weeks after the first session of treatment. They don't have a control group, so this is a big limitation of the study. Another indication is myofascial pain syndrome. Here there are very few studies. This is a recent of this year systematic review and meta-analysis of controlled clinical studies that included 10 randomized controlled trials for a total of 541 patients. The main diagnosis was myofascial pain syndrome of the neck and upper back, especially the trapezius region, and shockwave treatment, both radial and focused, has been compared with different physical therapies, TENS or ultrasound, or minimally invasive therapies such as trigger point injection or dry needling. This is the three main outcome indicators: pain, pressure, pain threshold, and neck disability index. And the authors found that shock waves in general has better improvement in these three clinical parameters compared with minimally invasive and other physical modalities, especially the high energies in focused treatment had better result compared to the low energy. This is the funnel plot that demonstrates that the studies are equally distributed, so there are no publication bias of the studies. Finally, a mention to the spasticity treatment. This is part of the neurological indication, but the effect of shock waves seems to be mostly related to the changing in muscle property, rheological properties. The mechanism of action is not fully understood, remain partly uncertain, but there are 4 hypotheses connected to the possible mechanism of action. We have an increase in nitric oxide production that lead to a better vascularization of connective tissues and a regeneration of neuromuscular junction. We have a decrease, a possible decrease in motor neuron excitability, so alpha motor neuron activity. A reduction, a peripheral action on neuromuscular junction due to the reduction in acetylcholine receptors at the junction. And finally, the most important mechanism seems to be the change in rheological properties of the muscles and tendons. Finally, this recent meta-analysis and systematic review of this year included 42 RCTs with a total of 1,937 patients with spasticity due to upper motor neuron injury, including both children with cerebral palsy or adults with post-stroke spasticity. They found a significant relief in spasticity after upper motor neuron injury after shockwave treatment, with results that was sustained for a month post-treatment. Here there are some final observation of the authors that shows how children have a better response to the treatment, and the efficacy of radial shockwave was superior to focal, probably due to the broader area of action and a more superficial action of the shock waves. The higher pressure frequency had a better antispasmodic effect, probably due to the higher total energy administered to the tissue. We have an important mechanical properties improvement in muscles, so the stiffness, the elasticity, and the tone of muscles are improved after the treatment. And finally, we have a decrease in electromyographic activity of the muscles. So it represents a potential useful tool in treating upper motor neuron injury spasticity. This is a panoramic of the literature. Here are only 3 slides about our clinical practice with extracorporeal shock waves. This is our generator, and these are our handpieces, the focal one, the radial one, and this is the focused handpiece that we use for treatment of burn scars or wounds healing. I personally perform an ultrasonographic evaluation of the area that I'm going to treat in patients to better define the area of lesion. For example, this is a patient with a minor structural lesion of the semitendinosus muscles, and to evaluate a possible associated alteration. For example, here we can see a lesion of the superficial muscular fascia. So in this case, I have to perform, I personally perform both focused shock waves targeted in the injured area and radial shock waves that acts mostly on the superficial fascia. So this is an example of treatment with ultrasonographic probe. I find the area, the lesion, the injury area, and then I put on the target point the handpiece and perform the treatment. Okay, thank you for your attention.
For the presentation. And there are just one question, and then I ask to the other people. In the review about myofascial pain, for me it's strange that the majority of the study are in the neck and the upper part of the trunk, because usually the people are afraid to apply the focal shock wave in that area. Is it just a stupid fear, or there are some problem to apply over the lung? Ci sono, ma... Okay, so in the myofascial pain review, the majority of the study were applied for the neck and trapezius area pain. And usually, for the focal shock wave, is an area where the people are afraid to apply the shock wave. Is a true problem, or is just something that is not true?
Okay, it depends, because if we have an instrumental guide that could be, for example, ultrasound, and we target the area, we define before the treatment the depth of action, we can avoid to damage any structure that we want to treat. So potentially we can use the focus shock waves also in the not in the neck, in the anterior area of the neck, but on the upper trapezius. There are no problem if the treatment is performed properly.
Okay, so it's only a problem to define the depth.
Yeah.
Okay.
And the level of energy.
Okay, perfect.
The parameters.
There are some questions.
During the shockwave therapy, there is immediately, if you do it to the hypertension area of the muscle, immediate some pain reduction. What is your explanation for this immediate pain reduction of 500?
Yeah, the immediate pain reduction is due to the peripheral nerve stimulation, inhibition of transmission of pain along the small nerve fibers. So this is the faster mechanism that induces reduction in pain, but the duration is very short. So we see the real biological effect of the shock wave after two weeks, about 10 days, 2 weeks after the treatment. The immediate action is on the peripheral nerve termination.
You use always low intensity shock wave or also the middle?
No. I always use the medium range of EFT in treatment ligament, tendons, and muscles. I sometimes use the lower intensity, for example, in treating very thin ligaments or Osgood-Schlatter disease in children to avoid to damage the cartilage, the growth cartilage. But in musculoskeletal disease, the range, the most used range is the medium energies.
What is your experience about the tendon insertion areas? You know, this is most of the.
Yeah, I have most of my patients have tendinopathy, calcific or non-calcific tendinopathy. So my experience is very good with the shock waves. I'm a physiatrist, so I always combine the physical treatment with shock wave with exercise protocol, or eccentric or concentric protocol. Depends on the pathologies and the level of pain of the patients to allow a better regeneration of the or repair of the tissue. So we know that the muscles can regenerate by the mean of satellite cells, while the tendons tend to repair, not a real regeneration.
This answer is now you make some multi-therapeutic approach to these patients, you know.
Yeah.
But to show what is the effect of the shock wave, you should also use some single shock wave therapy protocol.
With the aim of a study, with a publication, I only study the effect of shock waves. But in clinical practice, I have to combine the different techniques, but also in only with the use of shock waves in tendinopathies, the effects are very very good, especially in insertional tendinopathies or in plantar fasciitis. The better improvement, I noted that I can see the better improvement after 2 or 3 months from the end of the last session of shock waves. So I have to wait to see if the therapy has really act on patient symptoms.
Okay, last question. Yeah. You mentioned also spasticity, you know?
Yeah.
And I've missed a little bit the muscle spindle, and you didn't mention on the reaction of the shock wave. And muscle spindle and tendon spindle.
Yeah, the mechanism that are reported in literature are on muscle and tendons, on connective tissues, are more connected to rheological properties or muscle. There are few studies that focus on the spindle, the action of the shock wave on the spindle. So it seemed to be uncertain the type of reaction that we have by applying the shock wave on muscle in terms of spindle modified activity. It seems to be more, the effect on the muscle, it seems to be more connected to the change in rheological properties of the muscle due to the increase in vascularization, so in reducing stiffness muscle, while the non-neuronal effect seems to be more important than the neuronal one, or more demonstrated than the neuronal effect.
But I think that is a very good suggestion, because I have two. Because I have two suggestions. Just two suggestions about our study, because we have evaluated the role of muscle spindle in spasticity, and I think that they can play a key role. We have evaluated also the amount of hyaluronan around the muscle spindle, not in spasticity, but in aging and in other subjects, and the change. And we are publishing a paper about the focus of shock wave into fibroblast and fascial fibroblast. And we have seen that the input change stimulate the fasciocytes, the fibroblast, to produce hyaluronan. So we have a direct effect of the shock wave in a very fast way, because after 4 hours we have an increase of the amount of hyaluronan produced by the fibroblast of the fascia. So that input maybe can suggest that we have a direct effect of the shock wave into the connective tissue and probably also around the muscle spindle. Okay. So that could be a good idea. Sure.
Thank you for the suggestion. Yes. We answered your initial question.
I will have a more shocking proposal. It is not a joke. I think these 5 days are clear evidence that it is possible to have the support of basic science for clinical application. The data on the effect of shock wave on muscle regeneration either is a fake news, just constructed by Photoshop. You have to take in account this possibility for any published result. Or in Padua, there are the expertise to try to transform the Center for Neuroscience, together with the Interdepartmental Research for Muscle Research, with the goal to have a biological evaluation with 1, 2, 3 minimal animal experiment to compare any approach. Maybe we have to discuss this long time, but you have contact with bioengineers. You have contact with, I don't know what more. There is a lack of collaboration between the first 3 years and the second 3 years of the medical studies. It could be something absolutely original. The approach of Helmut is to convince people to do in mice in 1 month, to have a reference, to have every time whatever you would like to validate, to have also the same model of animal experiments that will help comparison between different approaches. I don't know if we will be able to collect it is only a problem of money. But we have to look to European Union funding and be able to construct something that respond to their call, but for our goals, not for I know that I started, it will be a shocking proposal, but it could be a long-term call. It could be, because to compare the study of fascia, the study of, and see every time to the same animal model to see if it is possible to compare results, even for what now Maria Chiara will present.
Thank you so much.